Welcome everyone to this first ever Flen Health Facebook watch party. My name is Tickle and I'm a tissue viability nurse specialist in Shropshire in the UK. I'm really excited to be joining you this evening to talk about self-care. So what is a watch party? Well, it's simple. I've pre-recorded a presentation for you and we'll all watch it together and chat about it in the comments. I'll be answering your questions and joining in the conversation throughout the presentation. So please don't be shy, type in as many questions as you like and I'll answer as many as I possibly can. I'd like to really thank Flen Health for putting this event on this evening. And Flen also have 300 hand hygiene tools to give away to nurses or clinicians who would find them helpful. You're able to find out more at the end, so it's definitely worth staying around until the end. Let's begin with my presentation. I'm talking with you this evening about wound care and self-care. And the overall learning objectives I want to address with you is self-care in our current climate. And, as we are aware, we've seen many changes in our current healthcare climate. I want to discuss with you what is self-care? What does it mean to you? What does it mean to the patient? And how individualised that self-care needs to be. I want to address who can self-care and diminish some of the myths that are around that only the able-bodied and the young can self-care. Offer you some clinical support about self-care and resources and tools available to you, and then give you some examples of how self-care can work, real examples of that self-care in practice. Let's begin though by looking at the wound demographics and the extent of the problem. I'm sure you don't need me to tell you the prevalence of wounds and particularly chronic wounds is on the increase. As you can see on the slide, there are over 300 million acute wounds, patients with acute wounds, over 20 million patients with chronic wounds, and in total over 400 million patients with given wounds at any given time. It's a massive problem and the prevalence is only on the increase. But to me, that prevalence and extent of the problem does extend to the patient. We are seeing so many changing demographics. Of course, we're seeing an increase in the elderly population. The elderly are living longer, and I hope I live longer too. But along with that becomes the increase of multiple comorbidities, multiple diseases and long-term conditions they may be suffering from, such as diabetes, arthritis. And along with that may mean more medication, increased polypharmacy. All of this will have an impact on their ability to heal wounds, but may also increase their risk of developing certain types of wounds. As we talk about the prevalence of wound healing, we also need to address changing demographics. As you are aware, and I'm aware, we're seeing an increasing elderly population. The elderly are living longer, and that is projected to increase, certainly the over 85s over the next 20 years. Along with that though, of course, we're seeing patients have more multiple comorbidities, more long-term conditions such as diabetes, rheumatoid arthritis and other conditions. In association with that may mean that they will be taking more medication, so multiple polypharmacy. All of this will have an impact on wound healing. It may delay wound healing or impair wound healing. It also may increase the risk of the patient developing certain wound etiologies. So that is a challenge to us in our communities. But also, what I need to discuss with you, we are seeing an increased number of younger patients with wounds. So I do want to emphasise that we mustn't forget the younger patient with a wound. If I give you an example of that, I have a young patient who's 18 with a venous leg ulcer, and you may add, well, how has he developed a venous leg ulcer at the age of 18? He actually developed a DVT from sitting cross-legged in front of a game console for many hours, and now he has a disease. He has venous disease, and he has that for life, alongside a chronic wound as well. And you can imagine the impact of that chronic wound on this person, particularly younger persons. So, imagine if you were a middle-aged lady with a wound, and I will always bring it back to the patient. Can you imagine coping with coping with life per se, coping with employment and holding down a job, coping with life stresses such as children and grandchildren and partners? Throw into that equation a wound. Throw into that equation of having to attend appointments and time consuming and the pain and the debilitation, massive impact. And let's not forget, we are seeing quite a number of chronic wounds with delayed wound healing outcomes and poor patient outcomes. Why is that when we have a great deal of evidence surrounding wound healing and wound management? So we need to address that. Is it because, very frequently the patients will see different members of staff, variations in care, and self-care can help to reduce some of those variations and encourage that standardised approach to wound care. Patients have greater expectations, and that's understandable, but I think patients should have expectations. They should, with discussion, be aware of what to expect in their wound, with their wound assessment, with their wound management and long term. As you can see from the images, we are seeing patients undergoing higher risk, innovative surgical procedures. As you can see, a patient with a disc abdominal wound. Many years ago, these patients may not have survived, but due to new surgical procedures, due to new innovations in wound care, these patients are surviving, and it's ourselves who are caring for these patients. And finally, looking at the prevalence and wound care itself, there are ever-growing increased healthcare demands. We are aware a great deal of wound care is undertaken in the community and also, of course, in the acute setting. But a great deal of wound care is undertaken by community nurses, practice nurses, residential and nursing homes staff also. But what we have noticed over the last 10 years is a decrease in the funding for community nursing services. We've also seen a decrease in the number of community nurses. But despite this, we're still seeing an increase in the prevalence of wounds. So this puts enormous pressure on us as clinical practitioners and enormous pressure on our healthcare providers. Of course, in today's climate, the COVID-19 pandemic, we've all discussed this on numerous occasions, but this is putting enormous pressure on you as healthcare providers and clinicians. It's putting enormous pressure on the patients. I know myself, working hands-on in the community, that procedures that would normally take us, say, 30 minutes are now taking us over an hour. And that's down to eliminating the risk factors, wearing full PPE for some patients, and ensuring that procedures are followed differently during this pandemic. But also the mental stress it's placing upon us as healthcare professionals for the risk of developing the coronavirus, let's be honest, and also the worry and stress for the patients when coming in contact with us as healthcare providers. So again, we must be mindful of that. And alongside the increased prevalence comes an increase of cost resources, which I know we are being stretched and pulled and under pressure to actually reduce cost in our healthcare arena, but that's extremely difficult when the prevalence of wounds are on the increase. But we do have to look at how we can be more cost effective as well as reduce costs also. Most important to me when we're talking about the prevalence of wounds and the impact on healthcare providers and the impact on you as clinicians is the huge impact and burden to the patients. When patients are having to wrap towels around their limbs, as you can see in the images, and plastic bags, just to stop their wounds from leaking, to save embarrassment. I mean, this really is not positive quality of life, but this is what we're still seeing. Patients who are young, the image of the patient's wound you can see on the left-hand side of your screen is a young 23-year-old lady, and the impact on her lifestyle and the impact on her, particularly around areas of, I'll give you a real simple one. We look at that wound and we might say her priority there is to actually heal that wound. Can I tell you that lady, when I first met her, that young girl, actually burst into tears, yes, because her wound was non-healing, but also because she didn't feel very attractive because of the wound. But equally, I'm sure you can appreciate, particularly the ladies in the audience, she couldn't shave her legs. And it's all those little things that we actually take for granted, we don't realise become a huge burden to the patients. So let's discuss, is self-care part of that solution? And I definitely think it is. I've been introducing self-care for quite some time in the area that I work in, which of course is wound care. But self-care is not a new concept in the UK. There's lots of national healthcare agendas and policies, and I'm sure worldwide there are lots of policies and guidance about supporting and encouraging self-management, self-care, about individuals taking responsibility for their diseases and taking actions to keep themselves well. And wound care is one of those areas that can implement self-care really successfully and quite simply, encouraging our patients to self-manage. It may not be for everyone, but certainly for a majority of patients, this is a solution. But what does self-care mean to you as a clinician? And I'd love to be live in the sense of seeing you face to face to ask you that question now. What does self-care mean to you? And maybe some of you can just jot some points down and share them with me as we're watching this presentation of what self-care means to you. And I'll give you a few seconds to do that. I'll give you some examples. Self-care could mean that you see the patient once a week. You offer them an appointment or you see them at home, and in between, the patient or their family member or carer carries out their own wound care. Self-care can mean that you see the patient once. You do that holistic, robust, evidence-based assessment. You involve the patient in making these clinical decisions about their treatment, and you leave them their contact details and information about how to contact you if there's a problem. Or it could be that the patient's family members self-care with their agreed resources and knowledge and skills. And again, you give them the contact details of how to contact you, and you don't see that patient again. Is that right? Self-care is individualised. Individualised to the patient and their own requirements and their own choices. And again, we'll discuss this in more detail. So we've discussed about self-care, we've discussed about is self-care part of the solution of the prevalence of wounds and chronicity, and I think, and hopefully you agree, self-care is part of that solution. But what will self-care mean? How can it benefit our patients? What will it mean to our patients' healthcare providers? Well, certainly to the patient, from my own experience and from speaking to other colleagues where self-care has been introduced into their work area, patients are actually verbalising that they feel ownership. They feel in control of their condition. They feel ownership for the care of their wound. Not pressure, because I think, from a negative point of view, people might say that we may put pressure on the patient. Let's remember that self-care is agreed self-care. We don't force it onto patients. Patients may disagree and say they don't want to undertake self-care, but this is empowering the patients that do want to take that ownership and do want to care and control their wound, but also take back control of their lives, take back control of their condition. For me, it means that the patient and the clinician are having early discussion not just about self-care, early discussion about their assessment of the wound, about the management of the wound, and making those joint decisions, that really good relationship between the clinician and the patient, and those patient decisions are being made. But it's at the right time, quickly, introduced quickly, but ensures then better outcomes, not only for wound healing, not only for the clinician, but for the patient also. And as I've just said, the most important feature for me is allowing that patient to contribute to that essential decision making. If patients are involved early on with decision making and to understand their condition and understand why a certain dressing is being used, really encourages them to continue with that treatment regime and encourages self-care as well. And I will challenge all of us listening to this evening, how many of you do actually sit with the patient and explain how the dressing works, how the cleansing agent works to help remove slough, how the compression works in assisting venous return. So we've discussed some of the benefits for the patients, and I'd like to share with you some of the real words that the patients have shared with me around self-care and what it's meant to them. One of my patients is discussed with me, I have the freedom to plan my day. Even though I cannot go out, I'm not waiting for the nurse to visit. And I've just discussed that, the stress of waiting for somebody to visit or fear that you're going to miss miss them calling. Another patient reported to me that they felt in control and not dependent on the nurse. And I think that's important. You know, not all patients want to be dependent on a clinician or another person or another family member. You know, they do want their independence, and this certainly is what the patient recorded to me. It's my leg ulcer. I'm more than able to change my dressing. Thank you for allowing me. So to thank us for us allowing them, this patient, sorry, to take care of their own leg ulcer, to take charge of their venous disease, to take charge of their condition, and allowing them to do that and giving them the skills to do that. That means such a lot to me, but also look how much it meant to the patient themselves. Let's look at the benefits of self-care for the healthcare providers then, as I've just discussed briefly. By introducing self-care early on, it means we are going to ensure that timely assessment of the patient's condition, underlying etiology. We're going to reach an earlier diagnosis and implement then a really clinical evidence-based management plan. What will that mean? That will mean more effective outcomes for the patient and for health, economic and wound care per se. We are going to get better outcomes overall. What it means for the clinician, and this is what's been reported to me and what I've seen in practice myself, is we get reduced clinical visits. Now, those visits can be the patient attending clinics or GP practices, but it could also be reduced visits to the patient at home or in the nursing homes, you know, because I'm sure some of you are saying, oh, we can't implement self-care in a nursing home or a residential home. Yes, we can. Self-care is individualised around the patient. You know, and certainly, you know, there shouldn't be barriers of institutions where we can't implement self-care. So that reduced clinical visits. Now that then gives clinicians release time to care. I think it's really important we hear this talked about a lot about release time to care, and it doesn't mean then that we've got time to twiddle our thumbs and decide what to do. It means it frees up time that we can be spent with other patients that need more of our time, such as the patients with end of life needs, for patients who we need to do more self-care education, for patients who we need to do more health promotion and health education. So it does release that time to care. It gives us more flexibility within our caseload if our patients are self-caring or share caring. It gives us more flexibility with skill mix within our caseload as well. It certainly shows very good evidence of partnership working, and by that I mean partnership working with your GPs, partnership working with carers, partnership working with social care, private carers and family members. And I think that's really crucial in today's healthcare. I really think evidence of partnership working and effective partnership working is the way to go. And certainly self-care can facilitate that. But what I found for me as a healthcare professional is that effective partnership working with industry. And I'm going to talk to you a little bit more about that later, but that effective partnership with working with industry that have produced self-care videos, produced really evidence-based patient leaflets and documentation that certainly I wouldn't have the time or resources to produce those, and I would work very closely to use those and encourage those for use by my patients and their carers. And as we've said, it has shown to give cost savings, significant cost savings to providers. But not just cost savings though, but cost effectiveness from a quality perspective, from reduced clinical appointments and better clinical outcomes for the patient's wounds. Prior to implementing a self-care pathway, it's really important that the clinician undertakes a risk assessment to risk assess and see the suitability of the patient and the patient's environment for self-care. That's really important. And these are examples of the sort of areas we would consider when risk assessing our patients for self-care. Mental capacity of the patient and consent, but also mental capacity to be able to retain the information we're giving. But it doesn't mean that this can't be shared care. If patients aren't able to give consent, but have a person who can give consent, this could be an element of shared care for that patient. Physical ability. Some patients may not have the physical ability to bend or to reach their feet or reach wounds to their limbs, or have the dexterity. So this may put them at risk of implementing self-care. But please don't let this stop you thinking that for some patients with reduced physical ability that they couldn't have some element of shared care. With any self-care pathway, there will be a criteria. You need to have a criteria, and I'll be talking about that in the next slide. However, if the patient's wound etiology or wound type or wound size doesn't meet that criteria, then really we assess the risk as high that they don't meet the criteria for self-care. Some frail or bedbound patients may not meet that criteria also. But again, it's very individualised and the patients must be assessed accordingly. Patients, or some patients, end-of-life patients, of course, we may not be suitable for introducing self-care, but that doesn't mean there might not be, again, as I keep discussing and mentioning, does not mean there couldn't be some element of shared care with their carers or their family members. Some patients with certain disabilities might find self-care difficult. I'll give you some examples. Some patients with severe rheumatoid arthritis, multiple sclerosis. Again, they may have problems with dexterity of their hands, they may have problems with mobility, and this may be an issue. But what I would like you to do is, if there are some patients with certain disabilities that you feel at that time from your risk assessment are not suitable for self-care, don't just then draw a line under that, because things evolve, treatment options evolve, products evolve. And I'll give you an example. Many years ago, quite a few of our patients would not have been able to manage their own compression therapy, certainly because we only had compression bandaging systems and very high, difficult to apply compression garments. Now, in 2020, we have lots of compression garments such as wrap systems, hosiery kits, which means that some of these patients that wouldn't have been able to self-care 2 or 3 years ago now can. So don't draw a line under those patients. Always be thinking possibly they can. Environmental restrictions, not everybody has running water. You'd think in 2020 that we have, but there's certain households that may not have running water. That will make it difficult for self-care. Maybe some patients who don't have access to a telephone, to actually a mobile, to IT or internet. Again, we probably find that quite surprising, but it's not. It's also that accessibility in some geographical areas of that access as well. So don't let that stop you implementing self-care, but you may have to look at different means of delivering that support in the sense of leaflets and audible systems rather than telemedicine. If the patient refuses to self-care or the carers refuse to self-care, appreciate that and respect that. Some patients and some carers may not want to look at a wound, may feel very distressed when dealing with wounds or looking at wounds, and we must totally respect that decision. Certain patients, as when we looked at meeting the wound criteria or certainly the inclusion criteria for your self-care plan, patients with very large complex wounds, you can see on the image here of a patient with a category 4 extensive deep ulcer. It would be very difficult, of course, for this patient to self-care and be a very high risk also. So it's not just about ability, it's also their risk factors. So patients with those large complex wounds may not at this point be suitable for that self-care consideration. Prior to implementing any self-care pathway or programme, there's always a process, isn't there? And sometimes, clinicians on the ground don't always see that process going on behind the scenes. And what I want to just very quickly just share with you is what that process might look like when implementing self-care. It's around 3 main key points: planning, implementing and reviewing. So with the planning phase, what normally has happened when we implement a new process, and in this case self-care, it's normally on the back of something happening negatively, such as a problem or a risk. So for instance, a patient may have reported they have had their wound dressing not changed for a week because the district nurse hadn't got capacity to visit. It may be patients or clinicians have raised concerns about their capacity within their team. So it normally starts with, unfortunately, a problem being raised, maybe at a quality meeting, a Datex meeting, or RCA meeting. But at least we're identifying a problem, and from that, we're going to look at how we can address that problem. So in this instance, how can we implement our patients and carers to be involved in self-care to stop that problem happening again? So of course, we'll identify who can get involved in that process. The organisation behind the scenes will be taking actions around that process, and we'll be drawing up guidelines and policies and care pathways to help to support that journey and implementation. And we will be looking at what I've just said to you, what patients may or may not be suitable, wound etiologies. You will have clear guidance on that inclusion criteria. And of course, it will cover all the aspects of consent, ethics and IG governance, which are so crucial, particularly when using IT and computers and telephones and etc. for sharing information. We'll then implement that and we'll roll that out across the organisation. If it's a small area, you might decide a pilot. But what I'll be honest with you about is since the COVID-19 pandemic, our self-care process has been rolled out very quickly because of the high demand and needs. Patients have actually articulated they don't want to see a healthcare professional. They will care for their own wound with advice and support, or their carers will do it. Care homes have asked us not to visit because of the risk to their patients, residents and themselves, and they have started to undertake that own wound care for those patients. And you know what? It's revolutionised self-care. It's just also meant we've had to do it a lot more quickly. But I think this is certainly going to stand in good stead moving forward for the future of self-care. We need to know how we can introduce that, and most importantly for the implementation for me is that early education, not just of staff, and we need to support our staff, but certainly the patient, the family and the carers, but at the right level, with the right tools and the right materials. So where are those materials going to come from? What do they look like? And I'm going to share a little bit more information about that later. And how we're going to document all that and have that availability to those resources. And then finally, after we've implemented self-care within your organisation, within your workplace, we of course need to know if it's working. We need to collect the data and review that. Not just about, it gives me some really rich data about the types of wounds our patients are dealing with, the types of wounds our nurses are caring for, and our clinicians, not just nurses, I must add. So it gives me some demographic data, but also it helps me to look at frequency of dressings and how we reduce that, or have we not, the outcomes for the patients, what's it meant to the patient, have we improved wound healing outcomes, or do we need to make amendments? So we do need that self-care process prior to implementing self-care, but don't let that stop you. Hands-on, clinician in the workplace tomorrow when you go to work. Don't let this process stop you. You can have the discussion with your senior members of your team, your TVNs and other senior members about the process if you haven't already got a self-care process in place. But the main priority for you is knowing what tools you can have and support and education so you can implement self-care for your patients. So that brings me on to trying to draw up evidence of what that checklist might look like when implementing self-care. And I've seen some really good presentations, some really good documentation around and articles and publications around self-care. And so some of this information has come from there. It's really important, to have that little checklist so that you're confident, your patient's confident that we've implemented that self-care safely. So of course, I've already mentioned we need to identify that the patient is suitable. So use your local guidance, use your local criteria to know that your patient is suitable and acceptable to self-care as well, with that consent and that discussion around it. That not just for your patients, the family or carers, if they're going to be involved, are involved in that discussion early on about what the treatment care may look like, what the options are, what the risks are, and equally how they will be supported in implementing and ongoing self-care. What the wound education needs to be, how it needs to be commenced, how it will be delivered, not only just to clinicians, but certainly the patients and the carers. Will they understand it? So this is where it has to be individualised. You know, it has to be in different formats. As you can see, it needs to be transparent and clear and reiterated. So, you know, for some patients, they just want real clear bullet points in a leaflet. Other patients may like a video to watch about how to change a dressing. Some may like a leaflet with pictures, pictorial, that show how to change a dressing, that show the signs of infection and they're clear. Others may want more detail. There are lots of tools out there that can assist. But let's also remember that some of those tools need to be audible for those patients with poor sight. So we need some audible tools that can discuss, you know, through tape recordings and through recordings of how to care for their wound, etc. And certainly for the carers as well. The checklist, as I've just said, the information needs to be in variable formats. We all, I think quite a lot of my older popular patients as well have mobile phones, but again, just think about their dexterity and also, you know, if they've got any problems visually. Sometimes tablets are better for these patients, you know, again, because they have a larger tablet to hold and to utilise the apps on that are easier. So think about different formats that you might be able to introduce. Telemedicine, making sure that, of course, we have access to that. That might be Skype, that might be just telephone consultations. But either way, I'm sure that will have been implemented through an IG and clinical governance through your organisation. But again, making sure that is not shared with anybody other than yourself and the patient. I was a little bit sceptical about patient diaries and self-care because some patients have said to me they found it actually time consuming to fill in, whereas quite a few of my patients have said at first when I talked about completing a diary and saying, you know, maybe on a daily basis or every few days, how it feels, how their wound feels, how their quality of life is. Some said, oh, I'm not sure how that will help, but quite a lot of patients have reported back to me that actually when they're writing or just you know, simply documenting, oh, my wound looks better today or it seems smaller, it actually does give them encouragement and reflect on continuing with that self-care and that management programme. And also it really does help clinicians to glean the impact of living with a wound. And I've learned a great deal from sitting with my patients or discussing with my patients over the phone or internet about the impact and the findings of their diaries. I really think it's important that we have narrative with our patients and it's not just written, because narrative, you know, is important in the sense of what's written down, or if a picture's sent to me, doesn't tell me if the wound is malodorous. It doesn't tell me if the patient's pain is improving. It doesn't tell me if the patient's quality of life has decreased. I need to hear that. I need to discuss that with the patient and with the carers. So narrative is important, and I really, you know, can't emphasise that enough. But we as healthcare professionals need to be involved with our patients' care as well. So we need, you know, if self-care has been introduced from a different care setting, so let's give you an example. If a patient's discharged home from acute hospital, has been taught how to self-care for their wound, the community healthcare professionals, the GP or the practice nurses, need to be informed of that, because it will be these clinicians that the patients may call or rely upon if there is a problem, or also rely upon for reassurance and motivation. So we need to be involved with that patient's care across all care settings if appropriate. Patients, of course, must have access to supplies, dressings, gloves, that goes without saying, but they need to know equally how to replenish that stock. That will be dependent on your local area. That may be via prescriptions with the GP, it may be through a direct ordering system, but that is for you to discuss. But they need to be aware of how to have adequate supplies. And, you know, from a cost perspective, they don't need months supplies. It can be week by week, but certainly just slight additional in case there's a problem with the dressing, or they drop the dressing, or the dressing becomes soiled. So bear that in mind as well from my own clinical experience. And certainly they will need advice, certainly from an infection control point of view, of how to dispose of the waste. And most of that waste is disposed normally. But of course, in today's pandemic arena, they need information about if a member of the household or the patient themselves is COVID positive, how to dispose of that waste appropriately. So following on from discussing checklists and risk assessment for our patients in self-care and self-care pathways, I'd like to now share with you some resources available. I mean, there's lots of resources available, and I would encourage you to, you know, after this event to start Googling and looking and looking at really good resources out there. But some of those resources might look like patient information packs, and what that will contain is obviously details of the wound dressing, details of maybe leaflets of how to change the wound dressing, maybe leaflets of how to cleanse a wound, lots of general different formats. Again, remember what I said though, those formats have to meet the needs of the patient and or the carer. So it has to be in their right language. It has to, you know, if we require pictorial, it needs to be pictorial. If we need more detail for some patients, again. So there's lots of different examples out there, lots of really good examples out there that you can use. I'm a big believer, don't reinvent the wheel, please, we haven't got time. Use those evidence-based leaflets and packs and, you know, use them within your organisation. The patient definitely within their information packs will need some really standardised information, of course. So it's contact details. Who do I contact if there's a problem? How do I contact them? When will I see a clinician again? You know, so that's in your negotiation of whether you will see the patient face to face again, whether it'll be just via telemedicine or telephone. That is that individual self-care programme. So contact details, but certainly also things, red flags, what to look out for if there's a problem, simple indicators of wound infection, what that might look like, who do I contact, what do I do, hand washing, applying dressings, and there are some fantastic videos out there for patients and actually for staff. I've been training redeployed staff recently who don't undertake wound care at all from where they work, and they've been redeployed into community nursing teams. And I have used these videos and they have been fantastic in helping to articulate and train our redeployed staff in applying dressings, compression therapy, hand washing and all those other factors. So please use them, guys. Patient-friendly videos, as I've said, there are many out there, and I'm going to give you some platforms in a minute in the next slide that you can log on to and join these platforms that will help and support you with some really fantastic patient-friendly videos. Patient diaries, and I know some of you might think, oh, you know, my patients won't fill in a patient diary. Patient diaries are good for all sorts of things, as I've just said, not just wound care. I find the patient diary really helps me to address issues such as unresolved pain. Because when they keep the diary and they're recording their pain when it occurs, what relieves it, what doesn't relieve it, it really helps you as a clinician to help to then reassess certain aspects of their wound care that need addressing also. You know, so I think they are important, and there are some fantastic examples of patients' diaries as well available to you. Let's not forget our local networks. I work very closely with quite a few local networks of specialist TVNs, of vascular nurse specialists, and also other networks such as lower limb networks for clinicians and nurses and staff and non-nursing staff who work with lower limb groups. These are an absolute goldmine of resources, of pathways, of patient leaflets, and all the things, and support to you as a professional in helping to implement self-care. There are many national resources available as well, not only in the UK. I would, advise you to look in whatever country you're working in. They will equally have their own wound care strategies also. But nationally in the UK, we have the National Wound Care Strategy Programme. I'm sure you've already heard about this, doing fantastic work, making great changes in the field of wound care. But they have some really good resources online that you can access for your patients, your carers, for yourselves. So I'll give you a few examples: how to care for a skin tear, looking after a leg ulcer, how to care for your wound, multiple resources there. We also have the fantastic Legs Matter campaign. I would ask you to sign up to that. It's a fantastic campaign for patients and clinicians who are helping patients with limb problems. They've got some fantastic resources for clinicians, but absolutely gives a platform for patients. The Legs Matter campaign does give a voice to the patients, and that's what's important. So we encourage our patients to join this Legs Matter campaign, to have a voice. And on that website, they've got lots of useful resources for the patients to use, and they've got a platform that patients can speak to each other as well about their condition, about the impact on their life, and give them encouragement and support also. And of course, the social national networks, such as the leg clubs, for example, the Lindsay leg clubs, where we've got that social interaction with the patient. It's more of a social event, but this is a really good platform to encourage and support and give motivation for self-care and shared care. So some very, very good campaigns there, and there are many more as well. But also, let's not forget, I've talked about working with partners, working with industry. I could not just in self-care, I couldn't undertake my job and do my job effectively and give my patients the resources they require without joining and working with industry, working alongside industry. Because they have some excellent resources available to them, best evidence, and obviously resources financially to support such documents that we can use in practice. And I would, advocate that you look at what is available through your industry partners to support you with and your patients with self-care. That, again, I've just said that may be videos. Here you can see on the screen, Flen Health do these really good self-care guides, pictorial and in obviously languages as well, but we've got pictures, and some of the examples there is general wound care, how to care for your wound, how to care for your pilonidal sinus, axillary sinus, and encouraging that self-care, giving the support that is needed there. So there are some really good self-care guides here from Flen, and as you can see, the links are on the screen. You can access those links and go and look at those and use those guides yourself. Equally, if you know your local representation from Flen Health, I'm sure they will support you in providing you with the printed leaflets and support with encouraging self-care and implementing self-care as well. But finally, what I would like to do is show you what self-care can look like and what it means to the patients, what it means to the clinician, and also what it also means in today's healthcare arena. Let me introduce you to Sue. Now, obviously, I have changed names. There are no patient identifiable details within this case study for those purposes. Sue presented to one of my clinics. She's 53. She's had a venous leg ulcer, as you can see from the image, with the hemosiderin staining and the skin changes and the varicose veins. She's had this venous leg ulcer for 14 months. It started as a trauma injury, but she has got venous disease. Now, she was seeing the practice nurse 3 times a week to have dressing chains and compression therapy. I'm going to give you a little bit of her background. She's married with 2 children. And what I want to say to you is just take a step back now and imagine that Sue is you, or Sue is your sister or a family member, and she's had this wound for 14 months and she's got children and she works in a school. What would that impact be on your sister or your life? Can you imagine that? The impact on trying to care for your family, the impact of trying to hold down a job with a weeping open wound. Sue reports high levels of pain and recurrent infections. And let me tell you, this lady in 14 months had had 8 individual treatments of antibiotic therapy. And I will be I was not convinced that all 8 courses of antibiotics were necessary. I think they'd have been prescribed unnecessarily. And again, that raises concerns for me: antibiotic stewardship, resistance, and cost. She was in a lot of pain. She frequently relied upon analgesia. She didn't necessarily want to keep taking regular analgesia, but had to because of the pain. She categorically said she did not want to have compression bandages. She totally understood. The practice nurse had done a fantastic job of educating Sue about venous disease and the importance of compression, but this lady said, I cannot have compression bandages. They're uncomfortable and I can't drive. I can't touch the pedals. I can't drive safely. And obviously safety is an issue there. I need to drive. I need to be independent. I don't always have the time to visit the practice nurse because I work, and I have to obviously visit the practice nurse in work, outside work time, which is not always possible. Probably the most important point that she made to me that made me stop and think was that she said, I just want my wound to stop ruling my life. I want to feel normal. And that really made me stop and think. We talk about wounds ruling people's lives, but for her, that was the biggest impact. She actually didn't say to me, Joy, I want you to heal this wound. She actually was more concerned about living her life and trying to be as independent and normal as possible. And I think that was really resolved with me for this lady. So, as we've discussed, I began involving Sue from the beginning. Now, what I want to say, I don't want to take any of that away from the practice nurse who from day one had involved Sue in her discussion. What I will say is that Sue's practice nurse maybe didn't have the tools and resources to encourage that self-care. And that's the difference, isn't it? If the clinicians have the tools and resources to implement self-care, then of course I may not have needed that discussion with Sue because it would have already been in place. But I started with that initial discussion with Sue, not just around self-care. I reiterated again about her venous disease, her condition, her wound. And then I started to talk to her about, well, what can we do that will make you feel in control? What can we do that will make you feel, and I hate this word, but make you, her words were, I don't feel normal. What will make you feel normal, Sue? And Sue's words to me were, I want to be able to change the dressing when I like, when it's convenient for me. I want to be able to share a bed with my husband, which I haven't done for 4 months because of the smell and the pain. So that was her other, we're being really clear here, real in-depth discussion about what is important to her and how we can introduce that. And she wanted to say, I want to meet with friends and meet with family. This was before the COVID, might I add. But I won't because I'm embarrassed, because I have to wear baggy clothes and clothes that are dark and don't show stains. So can you imagine, we hadn't even discussed the wound healing at this point. This was all about how we could improve things for her. And I very much started with that, with her saying that, if we can overcome those problems, then that would give her more confidence then, of course, in managing long-term her condition. So what did we do? We talked about self-care, of course we did. Sue was a little bit wary and saying, I don't know what to do. How do I change the dressing? What do I look out for? So we started with that knowledge and education, and we have to start there. So we use various resources and different formats to educate and support Sue. We use patient videos, which she loved because she got an Apple iPad and she loved apps and videos. So she's very confident in using those sorts of apps. She had a phone, so she liked the patient videos that showed her how to change a wound dressing. She liked the patient leaflets as well because she didn't always have access, of course, to IT. So she liked the leaflets helped her to have that reassurance that she got that she could read and look over and look at the diagrams or pictures if need be. She equally also joined, the Legs Matter campaign and started to look around and started to question me about her treatment, which was fantastic. That's what we should be encouraging, that, that dialogue between healthcare professional and patient about their condition. And I did ask her to, and I think that I'm being a little bit selfish, I think this was more for me. I asked her if she'd be interested in keeping a patient diary about the impacts or things that were working and weren't working in her self-care. And she did, and we gleaned a lot of information from that during her wound healing process. We arranged teleconference calls because we had to agree available, timely clinical review. But I didn't feel she needed to see me. I didn't feel she needed to see the practice nurse. She was very confident. She showed the skills of being able to apply her compression, and we'll talk about compression in a minute, and do her wound dressing changes. So we used it as a mobile telephone conference, or if we could, we would Skype. But she knew who to contact. She knew the practice nurses, she knew myself if there was a problem. And we gave her the confidence that we would respond in a timely manner, because that's important. If these patients are asking for help, we must ensure that that's in a timely manner. So generally that's what we did. And as you can see here in the image, after 8 weeks, her wound went on to heal beautifully. How did we do that? I didn't do anything apart from facilitate and support her. Sue healed her own wound by looking at her own lifestyle changes, and there was a few she did make regarding her diet, by implementing absolutely fantastic wound care and compression therapy herself. Now, when we talked about Sue's fear of wearing bandages because she wouldn't be independent, the evidence allows us, and it's only working with health evidence and nursing evidence and wound care evidence that we can support this. So the use of hosiery kits, studies that have shown, the Venus 4 studies that shows that hosiery kits are just as effective at healing a leg ulcer as bandaging. And so she had a choice. Would you like to wear a hosiery kit? So yes, I would. I feel normal. I feel more like a lady. I feel more feminine. I don't have people looking at me saying what's up with your legs at school because they see the bandages. So again, all those factors, but she could apply the hosiery kits easily, as often as she wanted. She can wash them, she could wear them. And those are the key factors we put in place for her. And I'd like to share with you some of the words she said to me when she healed, and we did discharge Sue from our care, but also left her with those contact points, those contact numbers in case there was any reoccurrence. Because as we've said, wounds can reoccur, conditions, certain etiologies, and we needed Sue to be supported if she did need that input later on. What she did say is, I just love my life now. I'm going out more, I'm socialising more, I'm wearing the clothes that I love to wear, and I'm now sharing the same bed as my husband. And these little things might sound a little bit silly, and you might think, oh, well, yeah, that's nice. But imagine if, again, I'm going to take it back to you, if that was you or your sister, your brother, or your family member. That makes such a massive difference. But the only thing we did here was encourage and implement that self-care pathway. And, it wasn't difficult. The most time-consuming time, and it wasn't time-consuming, but the thing that took the most time was actually the early on discussions and involvement. But again, I think that's what we should be doing with all of our patients, irrelevant of whether they're self-caring or not. So my final case study I'd like to share with you is a lady named Annie. And rather than self-care, I want to talk to you about shared care, because I've mentioned that throughout this presentation. Now, Annie presented to one of my clinics, as you can see the image on your screen, with a really noticeable skin tear, trauma injury whilst gardening. Annie's 85, very independent lady. She does live with a daughter, but very independent, loves to garden. But Annie's high risk. She's got certain underlying comorbidities that leads her to be quite highly immunosuppressed. Now, this wound did occur just before the COVID-19 pandemic, so she attended a clinic. But obviously there was news stories around the COVID-19, the coronavirus, and I'm talking to Annie about, attending clinics for dressing changes. And of course she said, well, I'm worried and scared. I don't really want to be coming into hospitals or surgery or GP surgery or clinics because I'm at risk and I might get COVID and I'm going to, self-isolate, which is what was being advised. And a daughter was present with her. A daughter's very caring and helps mum, but doesn't require that much help. And her daughter equally said, well, for me, the impact, yeah, I'm scared equally about the COVID-19, but for me, on a practical point of view, I work, I've got family members, and I will find it difficult taking mum to and from appointments. And, I don't think mum should warrant a district nursing visit because she isn't actually housebound. So this is when we started to talk around, because you'd look at a wound like that and think, actually, you know what, wound dynamics, maybe that wound is too big to include in a self-care pathway. But don't forget what we've just said. This was different times. This was really scary, different, thinking on your feet times of the COVID-19. So I sat with Annie and her daughter and I discussed about self-care and teaching her daughter how to cleanse the wound, how to dress the wound on behalf of Annie, what to look out for. We used various leaflets. Annie was not happy really to use apps. She was happy for her daughter to watch videos of how to dress a wound, etc. But she tended to like the leaflets, if I'm being honest. But again, bear in mind the leaflets, she had slight impairment with her vision, so we had to make sure they were in the format that she could read. But again, there's lots of resources out there. But she liked the leaflets from the pictorial and reading and supporting her daughter, because remember, this is shared care. So we did that. We introduced what the red flags were, what to look out for, who to contact. So we introduced that nice pathway and documentation. We made the dressing regime easy, and I didn't actually talk about Sue's dressing regime, but what we needed to do is, I don't mean that in a derogatory way to the patient from the point of view of knowledge or to the carer, but the easier it is to use, the better, of course. So for these two patients, we did introduce the use of Flaminol in the sense of its ease to apply and a secondary dressing over the top. Very simple to apply. We had the self-help leaflets that helped to support that. Annie's daughter undertook that care for her. She had a weekly telephone conference call with her practice nurse. And then it got to where it was Annie's decision. She said, oh, I don't need to call you every week. I'll just call you if there's a problem. And at week 5, she did actually allow us to do, being a bit selfish here, fully protected home visit with PPE on to take an image of the wound and to support her in the sense of discharge, etc. And as you can see, the wound healed beautifully. And what I will say here, this was shared care wound healing, and all thanks to Annie and her daughter who undertook and embraced that shared care. But again, using the resources, the tools and the education that we gave her. So in summary, as we've discussed, self-care is not new. It's not new in any healthcare arena. We've always encouraged self-management, self-care with certain conditions, but certainly self-care and wound management is really crucial in today's healthcare climate. It empowers our patients, as you can see, it encourages that shared decision making, that collaborative working between the clinician and the patient and the carers, and that is vital in helping to support our patients. It also supports effective and cost-effective use of resources. We've proven that, not only reduced healing times, improved patient outcomes, improved patients' quality of life, but equally less use of resources, less nursing time or clinician time, I may add. It's not just nurses involved in wound care, so less clinical time, less resources being used because we're getting more improved outcomes. What I'd like to do is set you a challenge. I'd like you to accept my challenge. And if maybe tomorrow or maybe the day after or when you're at work, I'd like you to choose just one patient. Look at your caseload, look at your cohort of patients wherever you may be working, Look at the things we've discussed around facilitating self-care and who can and cannot self-care. And I'd like you to discuss with one of your patients the possibility about introducing self-care or shared care with a carer or a family member. And see if you can implement this into practice just with one patient. And I will promise you that you will see such positive outcomes for the patients, but also for you within your teams, within your workforce. So please accept my challenge. That's the end of my presentation. Thank you so much for being here with me for this first ever watch party. I really hope you found it useful. I will be staying around to answer questions for another 15 to 20 minutes, so there's still time to chat. I'd like to thank Flen Health for this evening's session. And if you want to find out more about Flaminol and how it works, or see the evidence on safety and effectiveness, visit their website, which you can see on the screen now. As I mentioned earlier, Flen have 300 hand hygiene tools to give away to clinicians who find them helpful. If you would like to get hold of one, you just need to go to the website, which the address is on the screen. We will also share the website address with you in the comments. Thanks so much for watching and have a good evening.